All right, let's get started. Today, we're going to build the essential toolkit for anyone interested in plastic and reconstructive surgery. Think of this as outfitting you with the foundational concepts that surgeons use every single day to restore both form and function. So, here's our game plan. We're going to start with the absolute bedrock, skin, and how it heals. Then, we'll start adding basic tools to our kit, like grafts. After that, we move up to the real workhorse of reconstruction, the flap, and figure out how to classify them. And we'll finish up with the really high-precision stuff, microsurgery. Okay, let's dive in. Let's just jump right in with a pretty complex problem. What you're looking at is a hand with exposed tendons after a nasty burn. That hand is being kept alive by a pedicled flap that's still attached to the patient's groin. So the big question is, how do surgeons even begin to think about a reconstruction like this? Well, the answer starts with understanding the very fabric of the body itself. And that fabric, of course, is the skin. You have to understand its anatomy and the way wounds heal, because that knowledge is the absolute foundation for every single reconstructive procedure there is, from the simplest stitch to the most complex transplant.
So our canvas is the skin, and it's made of three key layers. You've got the outer epidermis, which is our protective shield. Then there's the middle dermis, kind of the functional layer, with all the hair follicles and blood vessels. And then deeper down, you have the hypodermis, which holds the fat and the bigger blood vessels that feed everything above it. Now, if you're going to move tissue around safely, you absolutely need a map of the body's blood supply. And that's exactly what Taylor's angiosome concept gives us. It basically divides the entire body into these 3D territories, where each one is fed by a specific, dedicated artery. This is the blueprint for how we design and transfer tissue.
Okay, so once a wound exists, surgeons are at a crossroads. Do we close it by primary intention, bring the edges together with stitches for a nice, clean scar? Or do we let it heal by secondary intention, which means we let the body fill it in from the bottom up? That decision really depends on the wound itself. Of course, healing doesn't always go to plan, and it is absolutely critical to know the difference between these two types of problem scars. A hypertrophic scar, yeah, it's raised, but it stays within the lines of the original wound. A keloid, on the other hand, is way more aggressive. It grows well beyond the boundaries of the initial injury. All right, so we've got our foundational knowledge locked in. Let's start adding some tools to our kit. First up are the basic but totally essential techniques for covering up defects. We're talking about grafts and tissue expansion. Okay, pay close attention, because this next point is one of the most important concepts in all of plastic surgery. A graft is a piece of tissue that's moved without its blood supply. Think of it like laying down new sod. It needs a healthy, rich soil, a good wound bed, to grow new vessels and survive. A flap, on the other hand, brings its own plumbing, its own blood supply, right along with it. Now, when it comes to skin grafts, there are two main players. A split-thickness graft is really thin, which is great because it lets us cover huge areas, like in a major burn. The downside is it can shrink over time. A full-thickness graft is much more robust and contracts less, but we can only take small pieces because we have to be able to stitch the donor site closed directly. So how do we actually harvest these grafts? Well, this tool right here, a power dermatome, is used to shave off a very thin, very consistent layer of skin, in this case, from the thigh. It allows surgeons to get those nice, large sheets you need for split-thickness grafts with incredible precision. But what if you need more skin right next to the defect? This is where things get really cool. We can literally grow new skin. By placing a silicone balloon under the skin and slowly inflating it with saline over weeks or months, we use a mechanical process called creep to stretch the skin and generate brand new, perfectly matched tissue for the repair. It's amazing! And here you can see the incredible power of this technique in action. On the left, you've got this large congenital mole, a nevus, on a child's back. So what the surgeons did was place expanders under the healthy skin on either side. After inflating them, they could remove a huge section of that nevus and use all that newly generated skin for the beautiful closure you see on the right. So what happens when the wound bed is poor? I mean, what if you're trying to cover exposed bone or a tendon or metal hardware from a previous surgery? A simple graft just can't survive there. In these really tough cases, we have to bring in tissue that's already alive. We need the next tool in our kit, the living flap.
And this is the heart of the concept, right here. This is a block of tissue, an anterolateral thigh flap that's been harvested. See that structure hanging down? That is its vascular pedicle. It's the artery and veins that are its lifeline. It's what keeps this chunk of tissue alive when it's moved from one part of the body to another.
Okay, so with so many different types of flaps out there, how in the world does a surgeon choose the right one for the job? Well, we need a system. We need a way to classify these incredible tools so we can understand their properties and figure out how to best use them. To make sense of all the options, surgeons have a really simple and useful framework, the 5 C's. You can classify pretty much any flap by thinking about its circulation, its composition, its contiguity to the defect, its contour or how it's moved, and finally, if it's being conditioned. It's a really powerful way to break down any flap you might encounter. Now, within that bigger framework, there are a couple of classic systems you just have to know. The Cormack and Lamberty system. That's for classifying flaps of skin and fascia based on their blood vessel patterns, and the Maz is in the High system does the exact same thing, but for muscle flaps, sorting them by their vascular pedicles.
And that brings us to the pinnacle of our toolkit. What happens when the flap needs to travel a really long way? Well, we have to detach it completely and then re-establish its blood flow under a microscope. Welcome to the world of microsurgery.
Microsurgery really did revolutionize reconstruction. We're talking about the technique of sewing together blood vessels that are often only 1 millimeter or 2 in diameter. This completely frees us from the leash of a pedicle, and it allows us to do what's called a free tissue transfer, like taking tissue from the leg and moving it all the way up to reconstruct someone's jaw.
But after the surgery, the crucial work keeps going. We have to make absolutely sure that flap stays alive. And on the ward, that means constantly monitoring its vital signs. Is it a healthy pink color? Is it warm to the touch? Is it soft? Is the capillary refill nice and quick? These simple checks are so important for catching any problems early.
And here is a critical clinical pearl you have to remember. When a flap is in trouble, it's not usually a problem with blood getting in, the arterial side. Roughly 2/3 of the time, the problem is with blood getting out. It's a venous or outflow problem. And that kind of venous congestion means an immediate trip back to the operating room.
So how do we give the flap the best possible chance to survive? Well, it really boils down to this simple, memorable phrase that gets passed down. Keep the patient wet, warm, and comfortable. Wet means good hydration for blood flow, warm prevents vessels from constricting, and comfortable minimizes the body's stress response. Simple, but effective.
So we've built our foundational toolkit today, right? We went from understanding skin all the way to the high-precision work of microsurgery. But this field is always moving forward. So the final question I want to leave you with is this. As we get better at bioengineering new tissues and controlling the immune system, what new tools do you think will be in this kit 20 years from now?